On this episode of the Nurse Coach Duo, Jen and I sit down with Dr. Becky Lynn and have a very candid conversation about sex in midlife. She shares so much information in this episode and validates the changes and issues that some women and partners experience during this chapter in life. And again, validates that there is help out there. So buckle up and listen up. But first, let me tell you about Dr. Becky Lynn. She is a board-certified obstetrician and gynecologist at Evora Women's Health in St. Louis, where she brings a compassionate and comprehensive approach to women's care, and you will feel this throughout our interview with her. She also serves as an adjunct associate professor of obstetrics and gynecology at St. Louis University. Dr. Lynn specializes in perimenopause and menopause management, women's sexual health, and medical weight loss. She is a Menopause Society Certified Practitioner, a certified sexual counselor, and a fellow of the International Society for the Study of Women's Sexual Health. In addition, she is a diplomat of the American Board of Obesity Medicine, reflecting her expertise in treating weight-related health issues. She earned her medical degree from Georgetown University School of Medicine and completed her residency at Washington University in St. Louis. Her career includes positions at the University of Missouri, Columbia, and St. Louis University. Before transitioning full-time to Evora Women's Health, Dr. Lynn also holds a Master of Business Administration from St. Louis University. She is a former president of the St. Louis Gynecological Society, highlighting her long-standing leadership and commitment to advancing women's health in the region. We are so honored to have you on our channel today, Dr. Lynn. Let's get started. Also in this episode, we had a little glitch in the recording, and you will not be able to see me during the recording, but you will see Dr. Becky Lynn and Jen Schwar. But I'm there. Listen up, you can hear me, but can't see me. Enjoy.
Before we dive in, just a quick reminder. This episode is for educational purposes only and isn't medical advice. If you're dealing with a health issue, please check in with your healthcare provider. Now let's get started. And today on the Nurse Coach Duo, we have Dr. Becky Lynn. So welcome, Becky.
Thank you. Thank you so much for having me.
Yeah, thank you so much for giving us your time. So we included your bio whenever we did the intro. So we're just going to jump right in and start asking you questions. And part of your bio mentioned that you are a menopause certified provider and an ISSWSH certified provider. And I just, not everyone understands exactly what that means. So I was hoping maybe you could tell us a little bit about why you chose to do that advanced training and what you think it brings to your patients and the difference it makes.
Sure. So it's kind of a windy story. When I finished residency, I went into private practice and was seeing patients. I was in a small community hospital, and residency is very focused on labor and delivery and operating and surgery and all of that. And they didn't really talk a lot about menopause or sexual problems in women. So when I went into practice, all of a sudden people were asking me all about, I have low libido, I have painful sex. And I was like, I'm naturally, I want to help people. I'm like, nobody's ever asked me about their libido before. And so this was a long time ago. I got a card in the mail about a conference in Chicago about female sexual function. And so I'm like, I am going to that because I want to learn this. I went up there, I learned so much, and I came back to Missouri with so much good information and ways to help women. So I really started in the sexual area first. And so I utilized what I had learned there for a while, and then I ended up going up to the University of Missouri, Columbia, an academic setting. And there they help you hone what your specialty is. So I got a lot of referrals for sexual medicine, but as you can imagine, menopause and sexual issues go hand in hand. So I was doing a lot of menopausal medicine. So because I was doing both, I'm the kind of person where I search out more education. So I found ISSWSH, which is the International Society for the Study of Women's Sexual Health. I joined that. I did their courses. I did a preceptorship where I shadowed other physicians who were doing sexual medicine. And ultimately, I became very involved in ISSWSH and I was on the board. I was the advocacy ISSWSH chairman for a while. I was on several committees, and it was a blast and super fun to do that. I also ended up, because they're linked, doing a lot of menopause, and I had heard about NAMS, North American Menopause Society, which now they changed their name to the Menopause Society. I've been going to those conferences for many, many years, and they have a certification program where you need to study, you need to learn it all, and then you take a test and if you pass the test, you can become a certified provider, and then you have to do continuing medical education to keep that certification up. And I'm just the kind of person who I love to really learn a lot about a specific topic. So I've really combined the sexual health, the menopause society, and their conferences to be able to help my patient population. So I guess the second part that you asked me was like, how does this help my patients?
Yeah.
Well, I think that, medicine is so highly specialized nowadays. So I'm a gynecologist, but if you came to me and said, I need a robotic hysterectomy, I'd be like, I can't help you. I don't know anything about it, right? So, but I know so much more about menopause, sexual health. So, like, we all can't be specialists in all things. So, even within my specialty, there's more specialties. So, I feel like if someone's struggling with menopause or really wants to discuss menopause or menopausal symptoms or sexual problems with someone who has that extra expertise, then that's how I can help my patients.
Yeah, wow. That is so great. I mean, I'm so glad that you explained all that, because I just feel like women are just starting to learn about you, and you've been doing it for years. So,
I
I
have,
mean,
I
do you just
have.
feel like you're like the OG? Because I think you're the OG now. You are in that, like, that's awesome. So much experience. And I love to talk about ISSWSH. I've learned a lot about them since starting
Mhm.
what I'm doing, and of course, the Menopause Society, and really try to tell my clients about both those organizations
Yeah.
for their own education. But so in your practice, like when you're working with women in midlife, what are the most common concerns that women bring to you? I mean, we could probably talk for 8 hours here today about everything that you see and everything you do, but what are the most common concerns?
Mhm.
And then some of the different types of treatment.
Absolutely. So I would say the most common concerns that people come in with are the classic perimenopausal symptoms. So hot flashes and night sweats, mood swings. I see a lot of mood changes, depression, anxiety, panic attacks, and then weight gain. So those are the most common things that I see when it comes to perimenopausal symptoms. The list of perimenopausal symptoms is incredibly long. So it's, hot flashes, night sweats, weight gain, sleep problems, brain fog, low libido, painful sex, vaginal dryness, and the list goes on. So I would say, well, I said those couple, but also low libido and painful sex are pretty high up there on that list, and sleep problems too. So in my clinic, the way that I approach this is I'm fortunate. I have an hour-long time with my patients. And we really go through all of the symptoms that they're having, because we want to kind of understand, is this menopause or perimenopause, or is it something else? Because people can have anxiety that's not related to their hormones. People can have joint aches that are not related to their hormones. So it's really important to sort of get a really good history to figure out, is this something that's perimenopause or menopause. And then the way that I approach it is I like to give people several options, right? There's never just one answer. Here's your prescription, see you in a year. There are usually many options for treatment. And then I go through the risks, benefits, and side effects of what those options are. And then the patient can choose what works for them and their health goals.
That's great that you are able to give a full hour. We don't hear that very often, right? And I think
Right.
that that's a huge issue, especially whenever women are coming in with perimenopausal, menopausal issues, because it is, like you said, that list is very long.
Mm-hmm.
And the fact that you also, do sexual health as well is huge to me, because it's not like, oh, now you got to go see someone else. Now you got to go see someone else. And
Right.
in that hour, you might actually get them to talk about their sexual health
Yeah.
issues, because it's a
Yeah.
very, we still all have this stigma that we don't want to talk about it.
Right,
So,
right. We're very open about talking about sex here. And I think that's really, really important because,
Yes.
sex is just part of a happy, healthy life, like food, shelter, and sex. So why are we not talking about it? And
Right.
I feel like a lot of women are embarrassed and they feel broken and they don't realize that a lot of the troubles that they're having sexually, everyone else is having too. Like they're
Yes.
common, super
Yes.
common in the midlife for sure. And there's
Yeah.
plenty of good treatments and ways you can improve your sex life.
Yeah, maybe you could explain a little bit there of why is it so common? What is it? What is it that's happening in our bodies in this
Mhm.
time of life that are causing these sexual problems?
Yeah, well, fluctuations in hormones for sure. So perimenopause can disrupt your sex life for a variety of reasons. So a couple things happen. So some of sexuality depends on your testosterone levels. And for women, testosterone levels start to go down in your early 30s. So by the time you're in your 40s, you've got a career, maybe you've got kids, maybe you've got aging parents, your hormones are declining. That can really contribute to low libido. In your 40s, also your estrogen levels, I mean, depending, right? The average age of menopause is 51. So if you're 40 and your periods are regular, you probably have enough estrogen around. But if you're 49, it's very common to have vaginal dryness, which leads to painful sex. Then, if you think about that perimenopausal menopausal woman who's having hot flashes and night sweats and can't sleep, then she's exhausted. She doesn't want to have sex. She wants to be left alone. She's irritable and tired. She might have some brain fog. So that contributes to, lack of drive and whatnot. As women age, it becomes harder to reach orgasm. So that's partially due to lack of or lower levels of estrogen. And, when you have a sexual experience and maybe you struggling with orgasm, that kind of puts a little damper on it. Or you might say, oh, don't worry about me and just take care of you. And then you're not getting anything out of that experience, which can lower your libido because in order to want to have sex, it has to be sex worth wanting. Then, see, the list is long in this midlife, how midlife affects your sex life. Also, women tend to be gaining weight. And so then they don't feel good about their bodies, right? As they've gained weight. And a lot of women will say, I eat the same, I exercise the same, and my weight is just steadily creeping up. So that can affect how you feel about your body. Then throw into that teenage children or long-term relationship, right? Long-term relationships are difficult, right? So like if you and I mean, I like half jokingly say this sometimes to my patients, if you got a new boyfriend, your libido would be much better, but we don't recommend that. So, long-term relationships go through their ups and downs and have their own struggles. So there's so many things going on in midlife that contribute to sexual problems in women.
Oh my gosh, you've got me thinking. So, one of the things is, so just moving on from that, what do you recommend to your clients about, intimacy, continuing that to have that intimacy communication in this time of life with their partners? One of my thoughts is, do you have couples come in on together? I'm just
Yeah,
curious.
sometimes.
Yeah,
Yeah.
sometimes, yeah.
So I'm also a certified sexual counselor. I
Mhm.
can't legally call myself a therapist, but I did do training and become a certified sexual counselor. So sometimes I do have them come in together, and I think that's a
Nice.
really good idea. And sometimes I will, meet the woman for, and I'm being heteronormative. Not all partnerships are male,
Right.
female. But sometimes I'll meet the woman first and then she'll bring her partner in another time and you'll get a whole different side of the story. And so when you're trying to solve and trying to help people, sometimes having both partners in the room can be very, very helpful.
Yeah. Well, I think Jen and I have probably heard from clients that women are being dismissed, right? When they don't have an hour, especially. So all different types of care. And, I was just thinking that, that dismissal then sets you back a whole nother like visit, right?
Right,
To
right.
be told to go do something else or try this.
Or try a glass of wine, which is not the right
Yeah,
answer.
or you
Not
read
the
this
right answer.
book,
Yeah,
and it's very
yeah,
frustrating for women that have done that already. And so,
yep.
how
So I
would you?
think, can I just say, I think there's two reasons why that happens and why
Okay,
people feel like, why women feel like they're not listened to or they're gaslit or not heard. So one is the problems with our health system, right? So the way that traditional medicine is nowadays, most physicians work for a very big hospital system. They're employed, not all, but most. And their employers like, you got to see 40 patients in a day. So in order to do that, you have 5, 7, 10 minutes with your patient. And so when someone comes in and they have, let's say, low libido, that is not a 10-minute visit. That's just not fair to the patient. So, I think that the patients feel like their doctors are gaslighting them, but the doctor, number one, has no say in how many minutes they get with the patient. And then the way that our system is, that's just what you get. The second thing that I think contributes to women feeling like they can't get what they need is we've had a whole roller coaster ride with hormone therapy. So in the 90s, we put everyone on Prempro. That was the formulation that we used. We thought it lowered your risk of cardiovascular disease. So the NIH paid for the Women's Health Initiative, which was a huge double-blind randomized placebo-controlled trial looking at Prempro versus placebo. And they stopped that study early because they found that women on Prempro had an increased risk for blood clot, heart attack, stroke, and breast cancer. And that got a ton of news media attention. Everybody stopped their hormones. And it scared everyone. What did not get the media attention was that those risks were different based on your age. So when they broke down the data, 50 to 59, 60 to 69, 70 to 79, women in that 50 to 59-year-old age range did have a lower risk of cardiovascular disease, no increased risk of stroke, and a decreased risk of dying from anything. That got minimal media attention. But what happened was people stopped prescribing hormones, training programs, stopped teaching residents and medical students how to manage menopausal symptoms with hormones. And so we have this whole generation of trainees that don't know anything about it. So, just like I said, you can't be a specialist in everything. A woman might go to her OB-GYN. You would think, oh, my OB-GYN will know how to manage this. But there's a whole generation of OB-GYNs who didn't learn a thing. So I think those are two reasons why women are feeling gaslit. And the other thing to say is now, fast forward 20 years, we know a lot more about hormone therapy. Prempro is not our first choice. There are other safer options that are available. But yeah, I think that's why it's been so difficult for women to get the care that they need.
Yeah. Yeah, and I appreciate the way that you explain that, because it makes it very clear, right? Like why we are stuck in this place. But I also, what makes me even more so want to commend you for getting the extra education, right? Because we have to like also expect that someone can be out there to help us,
Yeah.
right? And I think that people like you being out there, and we've met Angie and I've been very lucky to meet other people, other providers that are getting that information out and have that knowledge, which I think is super important. Which also brings us to the point of where hormones can help, right? So I do some education around like the cycle, and I'm always like, you come up to this ovulatory phase and all of a sudden, you're tapping your partner's tush a little bit and you think they're pretty cute. And that, guess what? You're ovulating. Your body is saying, hey, I'm attracted to this person. I want something, I want to be sexual with this person. Well, when you start to go through perimenopause and menopause, we're not getting up to that peak, right? We're not getting that surge, and so I think that our partners start to feel like we're less attracted to them, right? And there becomes this whole narrative of, instead of understanding biologically what's happening, it's becoming a, you don't love me anymore. It's a personal thing. So
They
maybe
feel rejected.
Yes, exactly.
Yeah.
So maybe can you talk a little bit about kind of like that whole desire, arousal, what's
Yes.
happening in the body, and how you manage that with your clients?
Yeah, so this is super common. So a couple things is that men have 10 times as much testosterone as women do. Their sex drive will always be significantly higher. And you're absolutely right. Like around ovulation is when women's testosterone is the highest. But as you get into your 30s and you have a job and a career, and now your testosterone is declining, you may not notice that increase in libido around ovulation. And women get busy, and so there becomes this like disconnect. Men, and like I said, I'm being heteronormative. I
Sure.
realize not all couples are male,
Yes.
female. But in general, men have much more testosterone than women do. And the other thing that's important to keep in mind is that there are two types of desire. So one is spontaneous, out of the blue, I feel like having sex, right? The other one is a responsive desire, where maybe you're not thinking about sex, but maybe you see a sex scene on TV and you're like, now I'm a little interested. And in general, men are more likely to have spontaneous desire, and women are more likely to have responsive desire. But society tells women we should all have spontaneous desire. So then we go around going, what's wrong with me? I never want to have sex. I'm broken. What's wrong? When really it's normal. It's normal for women to have that responsive desire. And the second thing is that men get that same message. Women should have spontaneous drive. So men look at their partner and be like, why do you not want to have sex with me? Why don't you initiate? That is the biggest complaint that I hear. Why don't you initiate? And women are like, I do love you. Our relationship is, I just don't think about sex. And so there's definitely this, it's kind of like sexual desire discordance, right? One partner's here and one partner's here. And so what I do is I help people sort of meet in the middle, and help, because if you have low libido and you don't care and your partner doesn't care, it's not going to hurt you. It's not a cancer. You don't have to do any treatment for it. But if it's really affecting your relationship, then there are plenty of things that you can do, both medicines and non-medicines, to improve your sex drive.
Yeah, can you give us some examples?
Sure.
Yeah, that'd be great.
So when we're looking at non-medicine things, right? If you just want to do natural, because all medicines have risks and benefits and side effects. So a couple things that I'll talk about. So in general is to not, it's usually a good idea not to leave sex till 11 o'clock at night. In general, if you're a busy working mom, 11 o'clock, you're exhausted. And now one more person needs one more thing from you. That's not the best time for many women. And in general, men will use sex to wind down. And for women, it's not a wind down experience. It's they have to get wound up. And so that's, a little bit, that's probably not the best time. So I'll recommend, pick a time where you're not exhausted, you're interested, Saturday morning, Sunday afternoon. And some people will say, well, then it's not spontaneous because we put it on the calendar. And my response is, was it ever really spontaneous? Because when you first started dating, you wore your pretty bra and underwear just in case something were to happen. So that's one thing. The other thing that's really important is that it has to be sex worth wanting, because if it's not great sex, then why bother doing it? That's just good judgment. So a lot of women will, and this is all general, not everyone does this, and there's nothing wrong with this, but they'll have kind of duty sex, right? Where your partner wants it, he needs it. I'm just going to have sex. Don't worry about me. I don't get an orgasm. Let's just take care of him. There's nothing wrong with that, because we all do things for our partner that, for their pleasure. But what happens is then they don't get an orgasm. The sex isn't good. So the next time he wants to have sex, you're like, oh, that was not so great. So then you're like, why would I want to do that? As opposed to if you had a great orgasm and your needs were met, whatever your needs were, you'd be like, oh yeah, last time that felt great. So let's do that again. So we talk a lot about that and making sure that women's pleasure is focused on, because there are definitely couples, that I've met where after he comes, it's over.
Yeah.
No. It's not a one-sided thing. Like it's her turn next. So we talk about that. We talk a lot about erotic reading, erotic listening by yourself with your partner. Doesn't have to end in orgasm. But erotic reading and listening just gets those neurons in your brain firing again that think sexual thoughts. So those are useful. Communication is key, and communication definitely changes throughout a lifetime. I have like a handout that I give patients where there's just a couple questions that each partner can fill out and then come together and discuss. Because even in the best of relationships, communication can be an issue. And talking to each other about sex is a very touchy topic, because you don't want to make anybody feel bad, make your partner feel like they're not a good lover. It's a very, very touchy subject. And so sometimes counseling and sex therapy plays a role there. I'm going to switch now to the medicines. There are 3 medicines that we use to treat things like low libido. And it depends on if you're postmenopausal or pre or perimenopausal. For postmenopausal women, there's a lot of good data that testosterone supports all things sexual, libido, arousal, desire, orgasm, everything. The problem is there's not an FDA-approved product for women. So we're sort of left in the wild, wild west. You can do a compounded testosterone cream. You can use a product for men. Or what I tend to do, not all the time, but I'm switching to this now, is there's an approved product for women that comes from Australia. For the longest time, I used compounded. Then the Menopause Society and ISSWSH came out with recommendations saying not to use compounded. You should use a product for men. I tried to switch my patients to Testim. That was a disaster for 2 reasons. The pharmacies that I was trying to send Testim for men, right, but doing it in a female dose, would not accept my prescription written in the female dose. They would only accept it written in the male dose. And so I can say, well, I can tell my patient, don't do it that way, but someone's going to forget,
Yes.
right? I would forget. I'd look at my little tube and I'd be like, this is how, and
Yeah.
testosterone can have permanent negative side effects if you give someone too much. And the other thing, it's a little bit challenging to dose, but you can squeeze the gel into a syringe. So those are the issues that I've had with using Testim for men. Compounding I tend to use, but lately I've been switching over to Androfem, which is designed and studied in women. So I'm really looking forward to the day that we have that here.
Yes.
There are 2 other medicines. One is called Addyi. This is a pill that you take at night. It's not a hormone. It works through dopamine and serotonin. It's FDA approved for premenopausal women, although there's good data that it works in postmenopausal women. And in Canada, it's approved for postmenopausal women as well. And then there's a medicine called Vyleesi, which is an injection that you use when you want to have drive. So kind of like Viagra is used when you want to have an erection, Vyleesi is used for women when you want to have drive. And it starts working in about an hour and lasts about 16 hours. And it's also FDA approved for premenopausal women. I haven't seen any data on its use in postmenopausal women. So those are the 3 main medicines for libido.
Wow, that was great.
It's a lot of information.
A lot of information. And I'm so glad we're going over that. We're just giving our listeners such a thorough description, information of sexual health in midlife, which I'm so appreciative of today. Do you have women coming in that are like, all right, I can't communicate to my husband, and I don't want to do erotic reading. I'm not comfortable with that. I just want to try the Vyleesi, or I just want to try that. So do you have them start non-medication first, or what are your thoughts on that? I'm just curious. Or is it just so individual that you?
No, so it is individual. If someone's not comfortable with a certain thing, I'm not going to say, oh, you have to try that first, because that's, I think, a setup for failure. Because if you didn't want to do it, you're not going to do it. And I definitely have no problems if they don't want to, they could, when I gave all of those treatment options, they're just options and people can pick and choose what they'd like to do. The other thing is, it's not wrong to start with a medicine, because sometimes you go to the medicine like Vyleesi or whatever, and now sex is great. So it's a self-fulfilling prophecy where now it's better sex. So now it's not as stressful and we can't talk about it. And, so in a way, it just getting started on those medicines can really improve the sexual experience. And then the next time around, you're like, oh, last sex was good. Maybe I don't need the medicine anymore. So you can absolutely start with the medicines.
Yeah, and I just want to add as well, we don't have time to get into it, but I did want to just say that, we talked about a lot of people have pain with sex. So like we're talking about people who are able to actually have it without pain. We did do a podcast with Dr. Brooke Kalisiak, who's here in St. Louis as well. And so if you want to learn more about pain with sex, definitely go and check out that episode, just because time-wise, we won't be able to get as far into that. What I do want to just like say that I really appreciate your approach of one, communication, right? Because like you said, it's a very difficult thing, and it's something we all need to be able to do with our partners, but also giving women permission to want to have good sex and ask for that. Because I don't think enough women are putting themselves first, and when it comes to that, and it could be equal, but at least to a point of being equal, right? And I just really love that, the sex worth wanting. I think that's just that should be your tagline.
Yep. In order to want to have sex, it has to be sex worth wanting.
Yes, absolutely. I think that's a really great takeaway from this that I hope that women are hearing. So just for time purposes, we don't want to hold you too long. If you could just give one piece of advice to the women listening, if you had just one thing that you were able to give them. Usually people are like, "Can I have two?" What would that be?
So two things. One, you're not broken, right? You're not broken. There are plenty of things you can do to get your sex life where you want it to be. Number two, I just have to do a plug for vaginal estrogen. We didn't have time to talk about painful sex, but vaginal estrogen is exceedingly low risk, and it treats vaginal dryness due to menopause. You can have vaginal dryness in perimenopause. It is, it's like the best thing for the vagina. And so it treats vaginal atrophy, it treats vaginal dryness. It's one of the reasons of painful sex. There's a zillion other ones. But no one should be afraid of vaginal estrogen. And honestly, if someone tells you just use coconut oil, just use Crisco, ask for the vaginal estrogen. It is exceedingly low risk, and it restores the vaginal tissue to what it was premenopausally. It becomes thicker, moister, more cells make lubrication, more blood flow to the vagina, and Crisco and coconut oil don't do any of that.
And you're right on our soapbox, isn't she, Angie?
Yes. And also, I would say, I'm sure you tell your clients this, or your patients, is that you have to be consistently using it as well.
Yes, it's not a one-time thing.
Right.
Yeah, you have to use it on a regular basis.
Yeah. Oh, that's great. Well, thank you so much. Is there anything else we want to
Why don't you tell us where people can find you, where your office is, that type of thing?
Yeah, so my office is in Creve Coeur at Olive and New Ballas in City Place. We are Evora Women's Health. And actually, we are a holistic concierge medical practice. We have Evora Women's Health, we have Evora for men, and we have Evora for kids. And we really focus on the patient as a whole. We're Western medicine trained, but we like to have everything that you need, especially a woman, needs to be healthy in one supportive space. So we have an internal medicine doc here, we have psychiatry, we have therapy, we have 2 dietitians, we have a personal trainer, we have a gym in my office, we have things like aesthetics, massage, physical therapy, acupuncture, chiropractic. So really our goal is to provide everything that you need in one space, everything you need to be healthy. So yeah. So we're evorawomen.com if you want to check out our website.
That is awesome. Yeah, it's, a one-stop shop for all your needs right there. I love it. Yeah. Well, thank you again, Dr. Lynn. This has been super insightful. I think it'll be a really great episode for people to listen to. I know I'm going to be telling everyone to listen in. We really appreciate your time. And if you enjoyed this episode, please leave a comment below, and please don't forget to subscribe so that you hear more from Angie and I and our experts that we'll bring on to help you through midlife. And